You can start. You want to start? So welcome, everybody. Welcome to the G-ECHO webinars, which is hosted by the Gastro Foundation in association with Project ECHO, the University of New Mexico. Importantly, these fellow programs run every second Monday, and we're going to have an excellent presentation today by Dr. Sipho Nkandlalana, and it's really looking at a very important topic that we often under-assess, the assessment of nutritional status and the management of sarcopenia and chronic liver disease. So we really want this to be interactive. Put your questions in the chat, and then we can address it at the end, or depending on the questions, we can break and discuss during the presentation. Sipho, over to you.
Thank you, Prof, for the introduction. Good evening, everyone on the session, and thank you for this opportunity and for joining me tonight, giving this talk. Tonight's talk is assessment of nutritional status and management of sarcopenia and chronic liver disease. My name is Sipho Nkandlalana. I'm one of the first year gastroenterology fellows at the University of the Witwatersrand Charlotte Macleay Hospital. The outline of the talk tonight, I'll go through introduction, pathophysiology, nutritional assessment, management, and there will be a take-home message after this of the key point of this talk. Sarcopenia was first described by Iwan Rosenberg in 1989. It derives its origin from the term sarco, which means muscle, and penia, meaning muscle loss. It is a muscle wasting syndrome, which is defined by a reduction in the muscle mass and is often accompanied by a decrease in muscle strength and function. It is an underappreciated complication of end-stage liver disease, which occurs with a similar frequency as hepatic encephalopathy, and is actually been described to be more common than refractory ascites or varicose bleed. It affects 30 to 70% of patients that are known or diagnosed with end-stage liver disease, and it also affects about 300,000 people in the United States of America. Sarcopenia is classified as primary and secondary, and where it is primary, if it is age-related with no definite or clear cause, and in elderly patients. And also it's classified as secondary, where it is activity-related, or there is an underlying disease or disease-related. For instance, where there is severe organ failure, and also can be nutrition-related in patients that have got malabsorptive syndromes or diseases. Malnutrition itself, it affects about 20% of patients that have decompensated cirrhosis, and it affects 50% of adults with compensated cirrhosis. According to the clinical practice guidelines, it has been described as a synonym of undernutrition. Malnutrition and sarcopenia, they are associated with higher rates of complications, which include susceptibility to infections, hepatic encephalopathy, and ascites. And there are independent predictors of lower survival in patients with liver cirrhosis and in patients that are undergoing liver transplantation. And this figure is a brief overview of pathophysiology of sarcopenia in chronic liver disease, which is a very complex and multifactorial process. It includes a decrease in hormonal levels. Also, there's mitochondrial dysfunction in patients that have cirrhosis. There's an increase in ammonia levels with increased myostatin activity. Also, there's accelerated starvation in these patients with increased gluconeogenesis, with decreased amino acids as a consequence of that. This ultimately results in dysregulated proteostasis that leads to muscle mass loss. So it's a very complex process with multiple processes that are involved. And some of these processes, if we look at them closer, there's impairment in protein turnover, there's dysbiosis, there's malnutrition in these patients, there's hyperammonia, as well as these patients have got a chronic state of inflammation. In cirrhosis, there is an accelerated state of starvation, which increases gluconeogenesis. There's fat oxidation, and which leads to ketogenesis, and it is a state of catabolic. It is a catabolic state overall. And there's also alterations in the endocrine system, resulting in decreased testosterone levels and with impaired insulin and growth factor 1 pathways. And this diagram is just it's an overall summary of factors that contribute to malnutrition and sarcopenia in patients with liver cirrhosis, which include maldigestion or malabsorption. This is due to multifactorial processes such as decreased bile production. There's portal hypertensive enteropathy in these patients. There's altered intestinal motility. And in some patients, there is pancreatic insufficiency contributing to maldigestion. There's also altered macronutrient metabolism with increased protein catabolism and decreased synthesis with hyperammonemia. There's increased gluconeogenesis and glycogenolysis, as well as increased lipolysis, ketogenesis, and lipid oxidation overall. These patients also have hypermetabolism, which can be associated to or worsened by infections, also by chronic inflammation. In patients with cirrhosis, they also have a gut microbiome dysbiosis. Another contributing factor is physical activity. So it's physical inactivity, which can be as a consequence of ascites and hepatic encephalopathy, rendering these patients less mobile. And lastly, factors that contribute to malnutrition is decreased oral intake, which I presume this could be one of the most common contributing factors, especially in our patients that have got a decreased intake as a result of anorexia. Usually these patients have got early satiety, they've got nausea, and some of these patients have got cognitive impairment and they don't really eat a lot, or they have got poor diet overall. Nutritional assessment in patients with cirrhosis. Patients are stratified as high risk for malnutrition based on the two criteria, which is underweight, described as a BMI less than 18.5 kgs per square meter, and or with patients with advanced liver cirrhosis, is described by child Pew C. So patients that meet these two criteria are classified or stratified as having high risk for malnutrition. And these patients have to be referred to a trained dietitian for a detailed nutritional assessment. And patients who do not meet this or who do not have these two criteria, one of the two criteria, which is undernutrition or advanced cirrhosis, should also have a rapid nutritional screen to identify whether they are at high risk for malnutrition, or to confirm presence and also severity of malnutrition. There are two liver validated nutritional screening tools, which is the Royal Free Hospital Nutritional Prioritizing Tool score and the Liver Disease and Nutrition Screening Tool. Patients that are at risk for malnutrition or those who don't meet the criteria as that I've alluded above, that are not classified as high risk, should have a rapid screen using one of these tools. And then depending on whether they fall as medium or high risk, then they can therefore be referred for detailed nutritional screen, which includes a further evaluation for muscle mass, use of global assessment tools, and a detailed dietary intake, which is done by a trained dietitian. Nutritional assessment involves the use of a detailed dietary intake, including the use of a 3-day food diary, and a 24-hour dietary recall. And another tool that's used for a detailed nutritional assessment is the global assessment tools, which include subjective global assessment and the Royal Free Hospital global assessment. And the problem with these tools, which is global assessment tools, is that they rely on the information that's obtained during clinical evaluation without any objective measurements. And then this renders them very subjective, and they are usually inaccurate. And according to studies, they underestimate the prevalence of sarcopenia in patients with cirrhosis. This is the summary of what I've just alluded to, as far as nutritional screening and assessment in patients with cirrhosis. I'm not sure if my mouse is moving on your side. So basically, in patients with cirrhosis or advanced chronic liver disease, they are stratified based on 2 criteria, which renders them high risk if they are child PUC or if they are underweight based on their BMI. So if patients with cirrhosis meet these 2 criteria, they are high risk for cirrhosis and therefore should be referred for a detailed assessment, nutritional assessment, which includes subjective global assessment, Royal Free Hospital global assessment, and detailed dietary intake, and assessment of muscle mass using one of the modalities that I will allude to later on. And the rest of the patients with cirrhosis that don't meet the 2 criteria need to have a rapid nutritional screen using one of the screening tools that I've mentioned in the previous slides. And this will then ascertain whether these patients have got mild, moderate, or low risk for malnutrition. And those that have got medium risk for malnutrition will then also be referred for a detailed nutritional status. And patients with low risk should then be reevaluated on the outpatient department at 6 months or yearly, depending on the comorbidities of the patient. Assessment of sarcopenia in chronic liver disease, which is part of the detailed nutritional screen, involves the use of a CT scan, which is the gold standard for assessment of muscle mass in patients with cirrhosis. CT scan analyzes the cross-sectional area of abdominal skeletal muscles at the L3 lumbar vertebrae, which is normalized to height to calculate the skeletal muscle index. And the cutoff values are less than 50 square centimeters per square meter in females and less than 39 square centimeters per square meter in women, which have been used to define sarcopenia. This figure basically shows a skeletal muscle index in 2 male patients with cirrhosis, where figure A is a patient that has got a decreased skeletal muscle index, meeting the criteria for sarcopenia in males, which is low. It's 46 square centimeters per square meter. And B shows the skeletal muscle index of a male patient with cirrhosis that is normal, of 60 square centimeters per square meter. I just wanted to demonstrate the actual skeletal muscle index. The use of a CT scan is limited by cost and by exposure to ionizing radiation and availability for routine use for the purposes of sarcopenia, where it has been advised that this can be routine, especially can only be routine or can be used routinely in patients that are being worked up for transplantation, where they usually have a CT abdomen as part of a liver transplant workup. So we can use that as that opportunity, or we can take advantage of the use of CT scan in patients that are going for liver transplantation to determine sarcopenia in these patients where they've already been assessed to be at risk for malnutrition. But routinely for the purposes of sarcopenia, it's really limited due to the factors that I've already mentioned. Other modalities that can be used to assess for sarcopenia or muscle mass include the bioimpedance analysis, DEXA scan, anthropometry, and muscle ultrasound. Whereas these modalities, actually almost all of them have got limitations, especially in our patients with cirrhosis, due to fluid status. For example, the bioimpedance analysis is affected in patients with cirrhosis due to fluid retention, which affects its reliability for assessment of lean body mass. So in patients with fluid retention, it's not really a reliable marker or modality for assessment of sarcopenia. And the other modality that can be used is anthropometric measurements, which include BMI, mid-arm muscle circumference, for assessment of nutritional status in patients in the general population, or in patients that don't have or that are not affected by fluid overload. But the limitation with use of anthropometric measurements to assess for muscle mass is the inability to differentiate fat from muscle mass, and also they are very inaccurate in patients that have fluid retention, as our patients are commonly have ascites, they've got peripheral edema, or even generalized edema if there's severe fluid retention. Another modality is the DEXA scan. The limitation with DEXA scan is that it is unable to differentiate water from a muscle. As a result of this, in patients with edema, it can falsely overestimate the muscle mass measurements. And other tests, such as the laboratory tests that are routinely used in the general population as surrogate markers for malnutrition, such as serum albumin. In patients with liver cirrhosis, these are usually affected by the hepatic dysfunction itself. So it's difficult to use some laboratories in patients with liver disease or cirrhosis as the surrogate markers for malnutrition. And this slide is just a summary of some of these tests that I've alluded to for assessment of muscle mass and muscle function and muscle strength. As I've mentioned, we use CT scans measuring at L3 skeletal for L3 skeletal muscle index. We use mid-arm muscle circumference DEXA, and bioimpedance analysis and ultrasound, though these other modalities have got limitations in our patients who have fluid retention. And for assessment of muscle function and strength, the most recommended modality is the use of hand grip strength using a dynamometer, which has been shown in several studies that it can be a very good surrogate marker for assessment of decreased muscle mass or sarcopenia, and also frailty in some instances. Assessment of micronutrients is recommended in patients with cirrhosis, where it is advised that or recommended that it should be done annually in patients with decompensated cirrhosis. Where it cannot be performed, an empiric course of oral multivitamins and trace elements is advised. These include fat-soluble vitamins, water-soluble vitamins, and trace elements. Nutritional management principles in chronic liver disease. This management of these patients, nutritional management of these patients with chronic liver disease should be done by a multidisciplinary team, which should include a trained dietitian or a nutritional expert with specific focus on lifestyle, nutrition, exercise, and pharmacotherapy. And the aim is to achieve an adequate calorie and protein intake. And this should be adopted in patients with sarcopenic obesity, patients that have cirrhosis, where it should be catered to achieve weight loss without compromising protein stores. Studies show that a high energy, high protein diet improves a nitrogen balance, and the target daily energy intake should not be less than 35 kilocalories per kg per day. And the target daily protein intake should be no less than 1.2 to 1.5 grams per kg per day to replenish a sarcopenic state or a malnourished state. And it has been advised that the daily intake should be divided into frequent small meals or snacks given at the interval of 5 to 6 times a day, preferable into split 3 main meals for breakfast, lunch, dinner, and this with 3 snacks in between. For instance, mid-morning, mid-afternoon, and late evening. And the logic with this is that this decreases a starvation period in these patients, which is the key and the main contributing factor in these patients because of the accelerated catabolic state and starvation. So breaking meals in these patients and decreasing the starvation time has been shown to be beneficial. The late evening snack containing 50 grams of complex carbohydrates is very advocated, and it has been shown to improve nitrogen balance in patients with liver cirrhosis. And also some studies, they also support the use of branched chain amino acids supplements and management of nutritional management of patients with cirrhosis, especially when adequate nitrogen intake has not been achieved with the standard dietary plans. The recommended long-term oral branched chain amino acid supplement is to be no less than 0.25 grams per kg per day in patients with advanced cirrhosis. And this has been shown to improve event-free survival and quality of life in patients with cirrhosis. Protein intake should not be restricted in patients with cirrhosis. and patients with hepatic encephalopathy. And the optimal daily protein intake should not be lower than the general population in patients with hepatic encephalopathy, as it is usually believed that previously believed that patients with liver disease or encephalopathy, it was previously thought that we should decrease the intake, but the studies have shown that actually these patients shouldn't have any different intake rather than the general population with malnutrition. Enteral nutrition via nasogastric tube or parenteral feeding is recommended in patients with grade 3 or 4 hepatic encephalopathy that are unable to take adequate oral diet. So augmentation of nutrition in these patients via these routes is permitted. Then in patients with sarcopenic obesity, which has become common recently due to increased prevalence of NASH cirrhosis. In these patients with sarcopenic obesity, it has been advised that they should have a moderately hypocaloric diet of 500 to 200 kilocalories per day with adequate protein intake. That's similar to the general recommendations of patients with advanced cirrhosis of not less than 1.5 grams per kg per day. And this is to achieve weight loss without compromising the protein stores in these patients. The micronutrients as well as soluble vitamins, fat-soluble and water-soluble vitamins should be repleted if they've been assessed and found to be deficient, and then be reassessed once repleted. But as I've already mentioned, in circumstances where it is not feasible to do tests, it is recommended to empirically replace micronutrients. And the recommended sodium intake is 80 millimoles per day, which is equivalent to 2 grams of sodium, corresponding to 5 grams of sodium when added to diet. That's a recommendation a day of sodium intake. Another principle is exercise, which involves a combination of aerobic exercise and body weight resistance, is recommended to improve sarcopenia and exercise capacity in patients with cirrhosis. And the recommendation of 30 to 60-minute supervised walk and the use of light weights for lifting, such as hand weights 2 to 3 times per day is advised, with the aim of a total of 150 to 200 minutes per week. There's, according to literature, there's no specific evidence supporting physical therapy alone, or that is showed that the use of physical therapy alone reverses sarcopenia. Like I said, the specific focus is a multidisciplinary approach, and usually using all these principles together, including nutrition, exercise to achieve a good response as far as malnutrition and sarcopenia are concerned. Pharmacotherapy, the use of testosterone replacement is recommended in men with cirrhosis and sarcopenia, where they have low testosterone levels. This is used to aid muscle mass gain. But the usual contraindications to testosterone do apply in this also in this group of patients, which include which include a history of hepatocellular carcinoma, malignancies, and thrombosis. So the use of testosterone in patients with these precludes them from use of testosterone. Other therapeutic or pharmacological therapies are still topics of research, such as drug agents, including that include ammonia-lowering agents, myostatin antagonist. They are all currently topics of research, and there are no human trials as yet. So it's still currently a very interesting topic to look into. Other proposed interventions include reversal of portal hypertension with TIPS or by liver transplantation, where it has been stated that baseline sarcopenia is a strong risk factor for failure to improve muscle mass after TIPS. And it has been stated that baseline sarcopenia worsens hepatic encephalopathy itself. So there's a very strong, very important statement that sarcopenia itself actually can be a very negative surrogate or can be a contribution to these patients not improving after TIPS and sarcopenia, baseline sarcopenia just worsens hepatic encephalopathy after TIPS. So the use of these modalities should be decided with caution. And also currently there's no evidence that use of TIPS or liver transplantation primarily for the management of sarcopenia of frailty. So these TIPS and liver transplantation currently are not indications or are not indicated for management of sarcopenia due to some of the complications or points that I've mentioned above. Going towards the end of tonight's talk, the take-home messages that I have is that it's worth having and recognizing sarcopenia and malnutrition. As it has been stated, I've noticed that it's been repeatedly stated that these are underappreciated complications of liver cirrhosis throughout the world. So it is very important to recognize sarcopenia and to assess and these patients with advanced cirrhosis, as it has been proven to be a very common than thought complication of cirrhosis. And patients and all patients actually with advanced cirrhosis should undergo nutritional screening during admission, and also in the outpatient setting. This can be done at every 6 months or yearly, depending on the risk where they lie after nutritional screening, and depending on the outcome, whether they are medium or high risk, and then they can be referred for a further detailed nutritional assessment. And early interventions are very important in these patients that have been found to be at high risk for malnutrition, or because this decreases wait-list morbidity and mortality, and it also improves post-transplant outcomes should we intervene early in these patients. As far as the pharmacological therapy is concerned, currently is still a topic of research, and we look forward that in the future or in the near future there will be more studies looking into therapies that can assist in terms of accelerating or treating sarcopenia. Currently, there's limited pharmacological therapies for treatment of sarcopenia. That's the end of my talk. Thank you. These are the references And thank you for listening to me. This was a very overview of nutritional assessment and management of sarcopenia in patients with cirrhosis. I hope I've managed to bring some key points in this topic, but it's a very broad topic. So I would advise to just go back and consolidate. But the key point is just to bring it to attention and just to have, to think about when you seeing these patients that have cirrhosis. Thank you.
Sipho, thanks very much. Really excellent presentation on a topic that we probably underestimate and we don't actually deal with very well. Maybe Bilal, I can ask you for your insights in managing your patients, because these are really quite important complication to manage appropriately in patients who are on the waiting list for transplantation, particularly when patients might wait more than 6 months to get a liver. Maybe just give some insights from your side, practically.
Hi, Prof. Thanks so much. Yeah, so I think it is absolutely crucial and is furthermore a topic that has traditionally been somewhat poorly taught and directed at from medical school level, where we're still having patients that are getting to us on referred by other practitioners that have been taught to protein restrict, especially in the era of NASH and ASH, where essentially these are diseases of lifestyle, and nutrition plays a crucial role in managing these conditions. As Sipho pointed out, many of these patients are coming in with not just protein energy malnutrition, but also with multiple trace vitamin deficiencies. You then have your cholestatic liver conditions, which also add further complexity to deciphering. So a liver dietitian as one of the first stops for a patient newly diagnosed with cirrhosis is absolutely paramount. And when that can happen, a patient's trajectory is often far better than when you've already started losing muscle mass and losing ground. I think it's important to remember that ascites, being fluid, will take energy to heat up to body temperature, and just the caloric expenditure of that shouldn't be underestimated either. So management of ascites is also very important. I think, just in terms of emphasizing that midnight snack, and it doesn't have to be a midnight snack, it can be a pre-bedtime meal. I heard a point where an individual said that a patient with cirrhosis fasting for 12 hours is equivalent to a normal person fasting for 72 hours in terms of equivalence, because remember, there's no glycogen that's able to be stored within the liver that you and I would be living off in the initial phase. And I think that's something that's very important. Sipho mentioned all the importance of maintaining muscle mass for ammonia prevention, and remember that ammonia at the same time is toxic to your muscle cells. So the balance there again needs to be focused on. Patients going through a liver transplant should be remembered that these patients are going to be catabolic for some time. And it's the equivalent of getting an unfit patient to look at running the comrades, which we know is an impossibility. So why would we take a patient that we know is heading for major surgery and not try and prehabilitate them? The concept of prehabilitation is, I think, gradually catching on. I think it's still somewhat controversial, but when you're talking about just a series of exercises and muscle strengthening tools, I don't see how you can go too wrong in that sort of intervention. I know we are cautious with the use of modalities such as supplemental IM testosterone, the risk of thrombosis, the risk of undiscovered HEC propagation is there, and these risks should be explained to a patient. Remembering that you can render a patient somewhat inoperable with a portal vein thrombus, depending on the severity and improvement thereof. So, you know, the supplementals need to be carefully considered. I think it's exciting looking at the future with things such as the myostatin inhibitors and so on, and it'd be just interesting to see how those sort of therapies progress. The bottom line is, I think we need to identify our patients with cirrhosis earlier and have better interventions before they lose muscle, rather than thinking that we can try and get them to put on muscle whilst they're in a catabolic state and actively losing ground in terms of ascites development, hepatic encephalopathy, and so on.
Thanks very much, Bilal. Yeah, I mean, I think realistically, as Bilal is saying, you want to identify these patients as they hit your clinic with chronic liver disease. By the time they've got to the stage, they've got 10 ascites, you've almost missed the boat. I mean, it's obviously very important that you want to try and keep them in this optimal sort of state for transplantation, but one really needs to be starting well before that, and particularly our patients with autoimmune liver disease, on steroids, our patients who have cholestatic liver disease, which run into bone disease very early, even before they are cholestatic, will have significant osteopenia, osteoporosis. And so it's important that we kind of recognize that early and address it rather than waiting until they present at end stage. And I think what most of us are not, well, we need to be really actively involving our dietitians in as part of the multidisciplinary team. We see them both inpatients and outpatients. But we've got some, Sianda, I think you've got your hand up.
Hi, Prof. Thanks, Sipho, for a great talk. I've just got a couple of questions. One is, you know, in our setting, we've got a limitation in terms of resources. I know there's other tests in terms of testing for sarcopenia, and I don't know if, Prof, you may just comment on them, like the 4-minute walk test, sit to stand, as well as ultrasound.
Absolutely. So I think sorry, go ahead.
I can give. I've got a second and a third one. Then the second one was, does liver transplantation reverse sarcopenia for these patients? And then the last one is, a lot of our patients have multiple diseases, so diabetes, renal impairment, HIV, which all contribute towards sarcopenia. Does it matter what the etiology or what the main driving force is for sarcopenia in terms of outcome?
Thanks. Those are excellent questions. So I think in terms of limited resources, absolutely. I think you can actually 4-minute walk. I mean, I think if you looked at Sipho, if you looked at the amount of exercise that you were recommending, I think that's going to be, although that's actually what is absolutely right, what's recommended, it's really probably in our patients who have already established portal hypertension, ascites, and sarcopenia, it's going to be very difficult for them to actually have that, fit that amount of exercise in. And so I think what one really sort of underestimates the role of resistance training, so just using weights, that certainly can improve it, and just improving, just being mobile. So it depends on when you're seeing the patient, how realistically one can actually have a very active exercise program. But I think what we've shown is that a patient with end-stage waiting for liver transplant, just being mobile is very important. So when you talk about the assessment, certainly sitting to standing, the 4-minute exercise is going to give you very good and really quite easily accessible resource to try and assess the skeletal muscle strength and sarcopenia. But I think what we probably are not very good about is actually using the ultrasounds that we usually are using in terms of actually monitoring. Most of our patients will have a CT scan, and using that opportunity actually to do that more appropriate L3 skeletal muscle index. And so I think we need to, when we're doing this, we tend to be sort of kind of single-minded. We're looking, is there an HCC, is there a portal vein thrombosis? But using that opportunity, actually, I think to have a formal assessment. And I think we all need to change our mindset, how we utilize the investigations that we're doing on a regular basis. The other, I think, Bilal's put into the chat, liver frailty index. Yeah, so I think there are lots of things that we can use that don't require these significant resources, but I think we need to be looking at when we utilize the resources, to actually optimize our use for it. I mean, if we look at most of our patients will undergo a DEXA scan, we've heard that does have limitations, but I think it still gives you quite a good idea in terms of osteoporosis. If you've got significant osteoporosis, osteopenia, you're going to really have to address it quite actively. Your other question was, will transplant reverse it? Now, one of the problems is that if you think about it, when you're going into transplantation, the recovery phase is a very catabolic phase. And in fact, these patients often lose a lot of condition in that first month post-transplant. And that's where you really need to bring in your dietitian to really optimize optimize intake. And that needs to be adjusted on quite a dynamic way, depending on where they actually are and how well that liver graft is functioning. So if you're going into liver transplantation extremely sarcopenic, your outcome is going to be really poor. Your ability to actually get off the ventilator, to mobilize is going to be significantly affected in terms of actually getting hospital-acquired infections. So one really, although it can take almost a year to actually get back to where you are, depending on how severe the sarcopenia is. So one wants to really try and prevent that severe sarcopenia before going into transplantation, because it does take time, and it actually determines output in terms of actually your 6-month mortality. 1-year mortality is significantly affected. The multiple causes, I think that first slide that you showed us, Sipho, really showed that if we look at exercise-related, disease-related, and activity-related. So if you look at chronic liver disease, in fact, all 3 of those components play a role. So I don't think you can say that one component is going to determine the outcome of development of sarcopenia more than the other. But I think what it does show is that you need to address all those components. And what we often, and I'm sure Bilal will attest to that, is our patients with metabolic associated fatty liver disease, who have an increased BMI, we often underestimate the fact that they are actually malnourished. And so these are patients that really need to be actively involved in a dietetic program. I think there was a question. Sorry, Bilal, you raised your hand.
Prof, I've just put something on the chat. Furthermore, just for the fellows to maybe jot down, there's an excellent resource for patients that I give to them, and I'd encourage you guys to go in and have a look. This is a Canadian website. I think it's the University of Alberta that has set this up, called wellnesstoolbox.ca. Yes, it is predominantly Canadian in terms of some of the references and so on, but some of the absolute basic stuff that they've got in, and the explanations and the graphs and the little videos, I think are fantastic for patients to utilize. There's a section for cirrhosis and a section for inflammatory bowel disease. If you click on the section for cirrhosis, because that's what we're really interested in, is once you go into that, there are videos on exercising, and then there are videos on nutrition, or at least tips for nutrition. I found it to be very well set out, very simple for patients to utilize. And in the age of portable telephony with a mobile telephone. I think patients should be able to access some of these resources. So just as a tip.
Thanks, Bilal. And I think there was a question here: how do we actually explain to our patients, what is 1.2, 1.5 grams per kilo? I think almost more important than, your dietitian is going to give you insight into that, but I think what's also more important, depending on the sort of socioeconomic situation of your patient, what do they actually have available? So it's no use actually prescribing something that the patient can't afford, but there are very cheap protein substitutes, particularly things like beans, lentils, that aren't dependent, that are cheap. So it really is important that you actually look at what your patient has access to and work out a diet around that. So we look at, obviously the importance is not to restrict protein. Somebody coming in acutely encephalopathic, acute deterioration, okay, you're going to sort of gradually increase that protein. You're not going to necessarily start at 1.5 grams per kilo, particularly if you haven't got access to putting your patient into a high care. So often in those situations, you need to look at getting those calories in and then slowly building up the protein intake. I think Bilal has already mentioned that you've got severe sarcopenia. That's usually going to be a contraindication. These are patients who then are usually end of the road, particularly one of the problems with patients with cholestatic liver disease. One tends to often underestimate its severity because, in fact, they run into portal hypertension and jaundice, but in fact, they maintain their synthetic function till quite late and they're not encephalopathic. So one actually underestimates the severity of the liver disease and the nutritional deficits associated with that. What was the other? So the other question, a very, very important question, if somebody have massive ascites, how do we look at, or if they've got almost anasarca, how do you actually assess the BMI? And that can be problematic. And I think then you are going to have to rely on investigations to actually assess that appropriately. It would be very difficult to assess the dry weight. If you've got ascites, you could maybe potentially say this looks like it's potentially 20 liters there. But once you've got anasarca associated, you need to have more objective assessment. Have I covered? And so the other thing is that so Sipho very importantly highlighted the role of micronutrients. The reality is, we would have quite difficulty assessing that, but I think somebody who's got chronic liver disease, they're going to be deficient, and I think one should really just prescribe them. You're not going to do harm, and you're going to actually benefit your patients in terms of it. Any other questions? Any other burning questions? So I think Bilal, anything from your side that you think we should stress?
I've actually got a question for you, Prof. Just in terms of zinc, zinc supplementation.
Yeah.
So zinc supplementation is thought to benefit patients with encephalopathy, and specifically so in terms of alcohol-related disorders. But if you think about it, zinc is also then entering through your divalent metallotransporter and in your duodenum and competing with iron. And in patients that have portal hypertension and therefore iron deficient, I'm just wondering what your practice is. This is just something that I've kind of took over instinctively, found out a little bit about why we do it, but the more I think about zinc, the less convinced.
So firstly, one of the problems is actually getting zinc. Most tablet forms have got like 1.5 milligrams of zinc, so, you know, almost useless to use. But the Smart Zinc has about 60 milligrams of elemental zinc. If we looked at how we would, if we look at sort of in setting of Wilson's disease, you would go 50 milligrams of elemental zinc 3 times a day. And very importantly, as you say, you need to actually monitor what your iron stores are. In the setting of chronic liver disease, we would probably not usually prescribe more than 50 milligrams of elemental zinc daily as a smart preparation, which you basically, it's like a fizzy thing, and it's easily absorbed and doesn't have as much of the GI side effects. So we wouldn't go for high dose. It'd really just be 50 milligrams daily. And I think that's probably something also that we tend to underestimate iron deficiency in these patients with portal hypertensive gastropathy. We can drop the HB down to 4 without bleeding. And we probably need to be looking at parental iron more frequently than we actually do. Because it improves the quality of life, it significantly improves it.
Absolutely. And, you know, it was actually something that I was thinking about is, you know, I had a quick look. There isn't actually all that much on patient blood management in portal hypertension / patients on a liver transplant wait list, which is interesting. And, you know, I mean, I think more commonly we're more associated with venous-secting patients in terms of hemochromatosis and having patients on the other end of the spectrum. And my feeling is that the anemic patients are somewhat neglected in iron, parenteral iron infusion.
Absolutely. So they haven't had a sort of variceal bleed. We kind of seem to accept it rather than being very active in getting that HB up, which is also important when they, you know, just in terms of oxygen carrying capacity, ability to actually exercise. I mean, it all has a knock-on effect. So I think we need to be, we need to address that. There's something else I was going to, slipped my mind, something else. No, it'll come. So I think, you know, one needs to be like, in liver disease, patients do well if you pay attention to detail. And I think we need to take nutrition and really have an understanding of what we need to be addressing with our patients, and then actively involve the dietitian. And I think it's more than just sending a note to the dietitian. It's really active discussion. Where are we going? What are we looking at? Any other questions? So I think that Sipho was really excellent. I mean, it's going to be a great resource for all of us to go back to. So thanks very much.
Thank you, Prof. Thank you for the audience for listening tonight.
So thanks everyone for joining us, and really, Sipho, it was a fantastic presentation. Importantly, we need to thank ECHO University in New Mexico, and importantly, the India team from ECHO for their support. These recordings are always available on the Gastro Foundation site, and we really thank Gastro Foundation for this ongoing commitment to teaching to the fellows. Our next presentation is going to be on the 26th of June, and we're going to be looking at a very important topic, liver transplantation, indications, assessment, and importantly, that immediate post-operative management in the first week. And it's going to be Dr. Medisi as the presenter, and Bill Bobak will be facilitating the presentation. So well done, everyone. I would recommend you actually go over this talk and just have an approach how you're going to manage these with your patients, because I think this is something that, you know, we talk about diuretics with our patient, we talk about immunosuppression, but we need to have a simple approach to nutrition that our patients can understand and that we can implement. Thanks very much. See you. Bye.